Hi, everybody. Welcome to our final event of the Practitioner Insights event this summer of the 2022 Summer Internship Program. Just a reminder for everyone, it is being recorded. We'll start off with both Carter and Mary are going to talk a little bit, and then we'll have time for questions along the way. So I'm Tim Diet, the Executive Director of the Shepherd Higher Education Consortium on Poverty. Thanks to everyone who's joining us here late in the summer, at least in terms of our internship calendar. It's late. So we're really excited, really grateful to both of you, Carter and Mary, for joining us from the Camden Coalition. I look forward to you all telling everybody what that is. And with that, I'll let you all both introduce yourselves as you present. So just to save time. So Carter, go ahead and take it away.
Yeah, thanks so much, Tim, and thanks for having us. I didn't know we were the keynotes here, or the closeouts. It's a big task.
You are. You're the finale. You're the fireworks all going off.
See, if I had, I would have brought something more formal with us.
Yeah.
So me and Mary, we're just here talking. We haven't prepped anything. We're just here talking about kind of organization, our work. Both of us have worked at our organization for 8 years, Mary, for you, 9 years for me. And so we're just going to chat. Which means interrupt us as you think of something, because it'd be really great if this were a chat and not just us rambling, because I can talk and I will. So interrupt me. Mary, I'm going to save our introductions until I get to you. We'll both go deeper, because my sort of how I'm thinking about structuring this, I'll tell you a little bit about our organization. It's called the Camden Coalition of Healthcare Providers. It's a 501c3 nonprofit in Camden, New Jersey, which is a small city just next to Philadelphia. But I'm not going to really tell you what we do. I'm going to tell you kind of how we got to where we are. I think that's far more interesting. We're a little unique as an organization in some ways and very common in other ways, but our path is ours, and I think has its own lessons to be learned in it. So I'm going to tell you that. Then I'm going to hand it over to Mary. Mary can talk about her work and some of the challenges she faces, and then I'll take the ball again and do the same for myself, like me as a professional, kind of how we got to where we are. So we are the Camden Coalition of Healthcare Providers. We started 22 years ago, something like that, coming up on our 20th anniversary. And we started with primary care offices in the city of Camden. So back then, there were lots of kind of mom and pop primary care offices, less so today, but 20 years ago, there were lots, certainly a lot in Camden. And they have a real, obviously, as in terms of frontline healthcare providers, especially at the time, the closest connection to the community, like eyes on what is happening on the ground, far more than a health system would, right? And so these providers, and when I say providers, I don't just mean physicians, I mean social workers, I mean front desk, anybody that's patient facing in these offices, started to come together and say, hey, there are patients that we do a great job serving, and there are patients we don't. Who are those patients, and how can we do better? And so they just got together informally as a breakfast group. And then over time formed the organization, the Camden Coalition of Healthcare Providers. Name's logical, right? And at the time, really, we were two organizations in those early days. I think people think of us as what we now know as high touch care coordination. So we would kind of send social workers, send nurses, send physicians into the community to kind of work directly with individuals and help address their barriers to health. That's care coordination. But really, I think what sets us apart was we were also a data organization. So very quickly, we realized that if we have access to all the data that the hospitals own, everybody that kind of comes through the doors, all their prescriptions, all the notes, all the discharges, if we had all that information, we'd be able to do care coordination better, right? We'd be able to identify kind of who we should target, engage. And so our founder and executive director, Jeff Brenner, went to the 3 hospital systems in Camden and said, hey, I want your data. Hospitals aren't incentivized to just give you data, right? That's a huge risk, right? There's protected health information. They don't just give it away, right? They have to be incentivized to do it. And so you figure out the selling points. And one of them is we think there are a bunch of patients that keep coming up to your emergency room and clogging up the operations. Emergency rooms have to flow. They have to run real tight. And they have a certain purpose. It's an emergency, right? But a lot of patients are coming with behavioral health diagnoses because they're homeless and are unhoused, and they're coming for a sandwich or just one place to sit. Lots of reasons they're coming, but not for the intended reason it's clogging up the ED. enough so where that's a selling point. Hey, I can help free up your ED for what it's intended to do. Then there are also incentives about inpatient utilization, right? So in general, hospitals want people coming and using their services. It's called fee for service. They get paid to do that. That was true 20 years ago, more so than it is today, but it's still true today. But there were some little incentives around, all right, hospitals will be dinged. They'll pay a penalty if there's a readmission within a certain time period. And so Jeff and the organization went and they pulled on these financial incentives within the health systems to convince us that, hey, we'll find the people you actually don't want coming in because they were just admitted or they're clogging up your ED, they're causing problems. The people you don't want, we're going to go address. That's the incentive. And that got us a lot of data, and data is super valuable. So very early on, we became a care coordination organization and a data organization, which became relevant kind of in future phases. This was all around a time when there was a national kind of conversation about the cost of healthcare. Healthcare is very expensive in the United States. We spend far more than any other developed country, do not get the results for it. And there was an understanding kind of emerging that one of the big drivers was kind of where dollars were spent. So we spend, for every $2 in healthcare, we spend $1 in social services. The inverse is true in developed countries that have good health outcomes. They spend $2 in social care for every $1 in healthcare. So we just had to, we weren't putting the money in the right places. And so that was a part of the conversation, right? And so a lot of it was, okay, how can healthcare, one, target these high cost patients that Jeff was aiming for? And a recognition that to do that well, you have to address social needs, you have to invest more in social care. Both those things were kind of true. And communities across the country were understood that and were doing things like we were doing. If we stood apart, it was because of the data. But other than that, everybody was doing this kind of work. Lots of people were doing this kind of work. But we got, in many ways, lucky. Atul Gawande is a very famous author. He wrote lots of books, and he was an author at the New Yorker. He wrote an article on us. We deserved it, but so did lots of other communities. We got it. We got an article in the New Yorker. And that was about 10 years ago, right when I started. And so with attention comes resources. And so we all of a sudden had new resources and we could start to tackle this problem from different areas, right? And so we grew in scope. Our care teams remained mostly the same. We did not change geography. We continue to focus on the city of Camden. But we said, hey, one of the things that would improve care more than what we're currently doing is to pull all the different partners together, right? So we know that these different social service agencies are relevant. We know that behavioral health is relevant. We know that schools are relevant and the police is relevant and jails are relevant. Let's all figure out how we get everybody playing nice, playing together in a more coordinated way, targeted way. So that's one thing we did in the local communities. As part of that, we said, well, we're trying to fix a broken system. And the people that know what's broken about it are the people that have experienced that failure. Right? So how do you elevate the voice of those that actually the system is failing to a point of leadership, like meaningful leadership? They are directing programs. So that became sort of our next phase, was like, okay, how do we do this with partners and how do we do this with consumer leadership? Then we kind of rode that wave, and about 6 years ago, we launched, with the support of a large foundation, the National Center for Complex Health and Social Needs. And it's the recognition that lots of communities are working on similar problems. And they're working on it for what, at first glance, looks like very different populations, right? So it's really what unites these populations is that the system is failing them, right? Ultimately, they're not getting what they need out of healthcare services or social services. They become high utilizers of lots of those systems, or they avoid those systems. But in the end, the system failures for those populations result in poor health outcomes. But that can be pediatrics, that can be young children, that can be older adults, that can be middle-aged men that's been incarcerated, right? There's lots of populations that sort of fit in that broad umbrella. But the National Center said, okay, let's bring all these sort of misfits together under one umbrella and say, how can the systems do better at serving these populations? So that's what the National Center does. And I serve as the director for the National Center. I've been in the coalition about 10 years. And Mary has been on the front lines for as long as that, and operating in new programs with community partners for those times. That's the organization. Mary, anything I missed on the organization that we should say? I didn't describe us. I gave our evolution.
Yeah, that was a good history. I like that.
What should we do now?
Yeah. Well, I was thinking we would describe a little of sort of like the different.
Anybody have questions?
Yeah.
The different what?
Like the different levels of intervention.
Yeah, sure. Do you want to do that? You want me to do it?
No, I think you should do it, and then I could give this more specifics.
So I'll talk about individual programs that might kind of help you understand the levels at which we're thinking. So we continue to maintain that high touch community-based care coordination program, which means we try and find, when I say complex, I mean you have some chronic conditions and some social barriers and or behavioral health barriers that are driving the mismanagement of that condition, right? So the condition isn't being managed because of these other factors, right? And so we try and find folks that are the most kind of severe on that spectrum. So many of them are experiencing homelessness or have experienced homelessness, high rates of substance use disorders, high rates of mental health conditions, extremely high rates of trauma and poverty in life, right? So we try and find kind of those that the system is large, all adults. We don't do children, all adults, and engage them in community, work to help stabilize them, connect them to kind of the needed services, provide health education and kind of competence. But Mary, you're gonna do much better talking about this work than I am. Mary's a social worker. I am not. So I should not be talking to any patient. Oh, they want to hear more personal stories. How about we stop talking about the organization and talk about personal stories?
Okay.
So I'll round it out. So we do that. We also then run a health information exchange that takes the data from all the health systems and pushes it to one another and to the community providers. So if you have a patient and say you're a behavioral health provider, you deliver mental health services and your patient, John, goes to the inpatient unit, gets admitted to the hospital, you can be notified of that. And that way you can also share a care plan. So your behavioral health provider can talk through that system to the inpatient provider and provide them information. So the health information exchange is a very valuable tool. That's why I mentioned it in our origins. It's extremely valuable and a big play in this space. If we want to talk about the financial market of it right now, it's hot. I don't know. And then at the national level, we do two things. Well, three things really. We are trying to define what complex care is, right? Like who are those populations? You heard me describe it. It's super loose. Like who are those populations? What are the actual best practices for serving them? What are the skills you need to do direct patient care that's effective? So that's defining. We do technical assistance. So folks like Mary and myself, those that have been in programs, help others. We get hired and we come in and we help design systems, help activate consumers, right? And then the third thing we do, and this is kind of a super relevant space right now, is develop education, like training materials. There's lots of kind of angles we come at complex care. We are not a policy organization. What we are good at is we understand the problems on the ground in delivery and help activating consumers and partners to fix delivery challenges. The financial challenges are big. We can talk about them. We largely do not play at the federal level that would change large levers. We do kind of within healthcare's incentives. How can we access existing dollars? So it's not saying take healthcare dollars and put it in the social sector. It's saying how do we take healthcare dollars, use those incentives to help solve social issues. That's where we play financially. I'm just talking, Mary. Tim, correct us if we're doing the wrong things here.
You're good. You're good. So Mary, where were you going to go, and then maybe come to the students' questions?
Cool.
Well, I think we had talked about kind of we were going to do a little bit about ourselves, and I think I could try to answer some of those social work questions and that. So yeah, my name's Mary. I'm a social worker, and I've been at the coalition for 8 years. Just a few weeks ago, I had my 8-year work anniversary. And when I was an undergrad, I definitely didn't really even understand what a social worker was. That was kind of a journey for me to get work experience after college. I was an English major, so it wasn't really I didn't really understand the intersection with kind of social work, public health, any of that at the time. And it took some work experience to get there. And I noticed that I kept having women supervisors who had a social work background when I was working in like social service and community service agencies, and it drew me to the field. And it's been a really great place to learn and grow. I think social work is so broad in terms of all the different levels of intervention, working directly with clients all the way up to sort of like policy and to kind of those big picture macro, we would say, in the social work field issues Carter was describing, and everywhere in between. So when I came to the coalition, I was a few years out of getting my MSW, and I had been working on a research study, and it was a research study at the VA hospital. And they wanted kind of social work type people with that training to work in the research study to like approach participants, you know, get people to talk about themselves, and this was providers and patients. They were doing a study on like this primary care transformation. And I thought that I had never thought about that either, like research, that there could be a presence for social work in research. So if anyone's interested in that, like it was like another learning opportunity for me. And when that grant was over there, I had the opportunity to come to the coalition, because at the time the coalition was doing a randomized control trial of the intervention, the original kind of like core care management, intensive care management. And so I was working on a group that went into the hospitals and spoke to patients in their beds at the hospitals and said, we'd like to get to know you a little bit better. We'd like to work with you in the community when you get back to, you know, where your house or the shelter, wherever you might be in the community. We want to meet up with you after this and get to know you and get to know what your goals are and work together. And so we did that for like several years, because we had to get to a big number of people. So that was a really good opportunity for growth as well. And for the person that asked about medical social work, I think I saw that come through. That's probably about that. I could speak more about like, you know, social work in what, I guess I would be curious to hear what you want to know about medical social work in terms of like working in a hospital versus like a primary care setting versus more like a public health setting. I think there's really interesting things to talk about there.
Caroline, do you want to jump in? With or without camera, you can unmute yourself. Your call.
Yeah, I can speak a little bit on that. So thank you all for talking a little bit more about your experiences. Yeah, I guess what I was just kind of curious with that is because I'm interested in doing social work, not sure if that's the path I want to go. I'm also interested in public health. And so I guess kind of looking at combining those passions for direct services as well as public policy work, particularly with behavioral health services. And so I was kind of just wondering, I don't know if that answers your question, Mary, but I was just wondering, you know, if you had any experiences with that, and if you had, I think kind of where all those passions intersect for me would be medical social work. But if you have any other advice as it relates to that would be awesome.
Yeah. Well, I always am going to plug social work as like a field because it just has, I think the skill set you develop in social work is really applicable to any of those places. And the opportunity for specialization really comes, I think, after the MSW. You know, that's like, you get you probably know the programs, like the foundation year and then the specialization year, but it's still only 2 years. And so I think the skills are so applicable to whether it's more policy, whether it's direct service. You know, medical social work I think is interesting because I do think you'd be the most constrained. And I saw this, and I don't know, Carter, if you've seen this over the years, like social workers who work in health systems or in like medical systems, social work isn't like the lead. And that was something I think Jeff Brenner was like really, he always kind of preached that social workers was like, should be team leaders. And, you know, he was super respectful of the profession and wanted to elevate all of us to use that skill set and use that lens. But I think when I was working, because I would work a lot with the social workers in the hospital, like on, you know, this patient's getting discharged, where to, like, what's the plan? And it's often driven by like insurance and the hospitals stuff. And so it's like I don't think there's the flexibility as much in that in that area, I think it's great learning. I learned so much about like medicine itself and how that works. But so I think Carter could speak more to that too. Some of those system things where you just see like all the different competing priorities in working in that kind of context.
I don't have anything more to say that other than like an anecdote, which is my sister's a social worker in DC. She works for an organization called Bread for the City. And it's a social service organization, but also has an FQHC connected to it. And so she's a master social worker, and she had to implement a program that included a biosocial screening. And she's like, okay. And she told like the funder or whoever the organization was her plan, and it was going to be have a social worker do it. She's like, well, how would the social worker respond to the bio questions? And my sister responded, well, how would a nurse respond to the social questions? Right? Like we put a hierarchy that like medical first. And that's where we're going to start. And then the kind of the socials and afterthought. And unfortunately, that's what Mary's talking about is true. You'll have a team of social workers in a hospital, but really they're not the front end making any early assessments. They're sort of checking the box, and a lot great people doing good work, but the system doesn't allow them to do their job kind of effectively. And the culture doesn't prioritize.
Yeah. Yeah. So I would say like the public health aspect might be where you find more kind of flexibility and expansiveness to take on some of these things.
Okay, I appreciate that, as I'm kind of just taking all this into consideration, and I appreciate you all, taking the time to share with us more about your organization and all that. So thank you so much.
Yeah. Let's see. I don't know. Carter, are you going to do your personal thing? I could talk a little bit about housing first. There's the Camden interns, I see.
Oh, nice.
Hi. Okay. We have a question. So we do intern for the Camden Coalition. So I think we've seen how a lot of this works at the local level. So I was just curious, what types of priorities in terms of healthcare have you guys identified on the national level, and how do you go about addressing that?
Yeah.
That's you, Carter.
I know. There's just so many ways to do this, right? Priorities on the national level. So if I were to have the magic wand, right, a lot of the conversations have been, and I even teed it up this way, that how do we take healthcare dollars and fund like to address social gaps? That's the space we're playing in. That is not the solution, right? For lots of one, it's not the desired solution. You don't want it all going through the medical lens, right? We don't want all of life to go through that. But more importantly, if you were to take all the incentives within healthcare to address social needs, you still wouldn't have nearly enough money. Like it would not solve the problem. It wouldn't come close to solving the problem. What healthcare actually needs to do is just be really good partners. And that's complicated, but they need to be really good partners. And we need to get a more sophisticated understanding about what our role is in social needs and like addressing them, right? And instead, healthcare needs to invest in behavioral health. It is embarrassing. Like we're all talking about social needs and what healthcare can do. That's great, but we have abdicated responsibility for behavioral health. We have not invested nearly what we need to be doing. So that's what, in my magic wand, is getting healthcare to focus more on that. I can't say that that's core to everything I do in the world, right? We're much more about the workforce development. And so we work with behavioral agencies, but I'm more in that kind of what should healthcare be doing in the social space? Collaborating. That's what I do. The actual solution is deep investments in like really under-resourced institutions. Plus a bunch of other things, but like that's the big one. And housing, sorry, lots of housing. We need lots.
Yes.
So for folks who are less familiar with sort of the healthcare space, when you say behavioral, what would be some specific examples that?
Behavioral is an umbrella term that describes mental health and substance use services, right? So addiction and mental health together.
Other folks with questions want to jump in? Otherwise, Carter or Mary can keep going, I promise.
What should we do? We could.
Hi.
Who's that?
Zion. Thank you all so much for this opportunity for speaking with us. I'm curious to know, what is a day in the life? Like, I want to know a day in the life of Mr. Carter Wilson and a day in the life of Mrs. Mary Pillock. So can you walk us through how that looks?
Mary?
Sure. Well, I didn't even talk about my current role at the coalition, which is I'm a program manager for the Camden Housing First program that we run. So that's like a big thing to explain altogether. But basically, we started that program 6 years ago based on, and to what Carter was just saying, like everything we do at the coalition has really come from the people we're serving and that seeing the needs they're struggling with. They're telling us these are the needs in the community. So, and then we're trying to like lift them up and, like elevate those things, those problems. So like what Carter just said about behavioral health, addiction services, mental health treatment, I hear that every day from the clients we work with. And I work in our housing program, which we have 50 vouchers, Section 8 vouchers from the state of New Jersey to serve chronically homeless, medically and socially complex individuals in our community and put them in permanent supportive housing with wraparound services. And it's a housing first model. So the services are voluntary. There's no preconditions for entry. If you meet that eligibility criteria and we have a voucher for you, you can come into the program. The idea being that the stability housing would provide will then allow you to work on those goals you have for yourself. So a day in my life usually looks like a lot of support for our really frontline staff. So like I go in the community regularly with the staff, but I work with 2 incredible community health workers who have been with this program since the beginning, who have a panel of, we have 48 people in housing right now. Each, those people are assigned to these community health workers. So processing with them, problem solving, all of that stuff. I see a former community partner is on the line listening in who we have a housing partner in the community that helps us with all this sort of like property management piece. So some of that coordination, we have an incredible staff member at the coalition, a housing coordinator who does a lot of that work with landlords, a lot of work in partnership with him. I facilitate, we have a weekly meeting that we call our care planning session, where our group comes together with those community health workers, the housing coordinator, our medical director sits with us and reviews medical issues that are coming up, and one of our nurses. And we have an LCSW, so she kind of like does behavioral health consulting with us. And that's a really powerful meeting each week to kind of prepare for and then talk through how we can support the clients in different ways. What problems can we kind of support each other in dealing with? And then I also have to do some of the like grant reporting and that stuff, which is just like part of the job too. I think in the nonprofit social work, how any of that space, there's like someone has to report back to the funders, what's going well, how you're spending that money, all that stuff. So that's a part of my role too. But it's great because we get the opportunity to share, client stories and share some of the successes as well. So that's kind of what it looks like for me.
What about the popsicles at the end of the day, based on our prior meeting?
Oh yeah, I know. And I have 2 young kids and they joined me for the planning meeting for this. Summer is a lot of popsicles. Yeah.
What about you, Carter? What's the day look like?
Well, I'm a little wounded by that, Mary, because most of my day is grant reporting, like working with us. Well, probably about a third of it is. We're sort of, and actually, Mary, it's not that usual that a frontline social worker who runs programs would be doing grant reporting. It's not abnormal, but we don't bill Medicaid, which makes us, it's like one of the weird things about us is we're not in that traditional kind of healthcare funding structure. So we do grants. But anyway, my day, if you were to average them out, there'd probably be 3 equal components. One is grant reporting, right? I talk to a lot of funders, pitch them on projects, workshop that project to get them aligned, right? Try to find co-funders, a lot of that. Then it's managing those projects. The management of the projects, you could probably simplify it to say that there's 3 phases. capture information from people that's living in people's brains, not on papers and some academic journals, that like lives in the world, distill it, organize it, and then disseminate it back out. That's really what we do. And sometimes that dissemination is in curriculum, sometimes that's in white papers, sometimes that's in presentations. And I play varying roles in that. I'm not our chief writer. I do a lot of speaking for us. I do a lot of the kind of the designing of the project. I don't do a lot of the information collection. So different team members with different strengths play different roles in that, but collectively we're figuring that out. And the third piece is technical assistance. It's actually getting in there with an organization and saying, hey, what's your problem? Let's try and solve it. That one, they're all satisfying in some ways, right? The first one a little less so than others, but the last one's so satisfying because you're close to the problem. That middle one, which is a big part of the job, is fun. And there's like great things about it, but you feel so far removed from the problem. Like I do a webinar, we put out a course, we put out, does that change anything? Is anybody's life better? The theory is yes, right? But you don't feel that day to day. And that can be one of the challenging parts. Because I used to be on the team with me and Mary used to be on the team together. So.
Thank you so much. That answered my question a lot. As someone who is an aspiring doctor one day, I am in this internship trying to really figure out if I want to be on the clinical side of the medical field or the non-clinical side. And I'm just always curious to see what the non-clinical part looks like. So thank you for that. I do have one more other question. So at what point does the projects like stop? Like at what point do you think that, creating a project to help the community is effective, and like at what point do you stop like creating all these different projects to try to tackle like a chronic disease or anything like that?
It's a really good question. Mary, you want to go?
Yeah. I don't think I have a good answer.
I can rip a little bit. So we've always talked about us being temporary, right? That we're the connective tissue, that we're not actually the service providers in the long term. We're with you for a short time to help bridge the gap, but ultimately the system shouldn't have the gaps, right? So you don't need the glue. We don't talk like that anymore. I mean, it's just not realistic. It's not like it's not really understanding what is happening between these systems. But that doesn't mean that's not the goal. It doesn't mean that's not what you're pursuing. So sort of every local project we activate that's beyond just direct patient care, because there is like a need that you need to address, and we're doing that. But kind of in the future, the ones that are future focused about improving systems, which is most of them, it's how do we get this, how do we minimize our involvement? Like, is there a way that we can set up an automatic kind of communication, establish workflow, kind of establish target goals, governance, all those things that are needed for things to run without you? That's part of our mission. What I just described, do we hit that? No, I don't think we've hit that on anything, right? But we've made strides in lots of places, right? It's definitely better now than it was before. And a lot of that is the efforts of Mary and her team and others, right? But we do recognize that we're never going to hit that point. And so what the projects are, it's not.
Oh no.
A clean answer when you stop. Am I back?
Yes.
That happens a lot. Know that I can still hear you. So don't be talking. Mary she was gonna trash talk me. But it's not that clean, right? So then it just becomes, all right, is this worth the investment? Are we getting traction? Are other players picking up the responsibility? Or does it require, are we the engine, or are there now multiple engines in our system? That's the threshold you really want to hit. We don't always, and then it just becomes a cost benefit analysis. Like, are we achieving the impact that we want to achieve? And could we achieve more impact in another space? The answer is often yes. We shut down a lot of programs. Doesn't mean they were failures. Some of them were failures. Some of them were failures. Some other them were, we added the value we could in the time that we did, and the world's changed.
There's a lot of, oh, sorry, go ahead.
No. I was just gonna say that makes so much sense. And thank you for that.
I'm advocating non-medical, Zion.
I know. I see. You're kind of doing a good job. You got my wheels turning here.
I just think that, so I like in social work and in direct service, definitely, if there's like a constant need for reflection, self-reflection, you know, you're being sort of like, why am I doing this? Who is this really about? You know, like we can talk about triggers and boundaries and all those things that come up when you do direct service. But I think there's like a way to put some of that reflection to the organizational level. And I think that's part of what Carter's talking about. Like, what were we thinking? You know, sort of like doing that reflection. If you kind of need to do that to keep yourself like not burning out and honest in the work. And it's important. So I think sometimes it means ending programs or saying that was a failure and that's okay.
Any other burning questions out there? Got Carter and Mary. Not going to get them another night here. One night only.
We're closing down, right?
Closing it out. Everybody's headed to the beach or something. I don't know. No? Any other questions? Well, Mary and Carter, thank you so much for joining us. Thank you so much for sharing some of your experiences, insights with our students. Really appreciate it. Thanks to all the students for coming. And yeah, have a good night.
Thanks for having us. This was
Thanks.
very fun.
Yeah.
All right. Thanks so much.